Thanks for having me. I'm here from America's Physician Groups. We are formally CAPG, so if you didn't get that memo, we are no longer California Association Physician Groups. We went national 4 years ago and have officially changed our name to America's Physician Groups now that we're nationwide. So I am the Chief Medical Officer there. I also teach here, so I was just here last weekend teaching the MHA students at the Price School just next door. So I see some of my students in the audience, so thanks for coming. And I'm also a practicing family physician, so some of my comments are also from that and that perspective of a practicing doc. So the objectives, we all know, we're here to talk about affordability, cost, and I'll also chime in about quality. I don't think we've heard enough about quality this morning, so we'll do that. So just a little snippet about America's Physician Groups. We're 300 physician groups strong, nationwide, 45 states, Puerto Rico, and Washington, D.C. You see the map there. Every single member of APG practices some sort of risk-based coordinated care. So some sort of model of alternative payment model. So whether it's just shared risk, upside only, upside downside, ACOs, bundles, or full global capitation. That is our constituency. So that's what separates us from other associations and from other organizations. And our mission is to take responsibility for America's health. Big thing. So this is the risk continuum. I show this because it just kind of summarizes who is in our constituency, and you'll see the resemblance to the Healthcare Payment Learning and Action, the LAN network, the APM framework. So you see all the 4 categories here. We're trying to move this movement, as we all know, from volume to value, more into groups 3 and 4 in terms of population-based payment and value-based care. So the last administration, Obama's administration, January 2015, Secretary Burwell announced really big to-do about this tying value to payments, so aligning payments with providers, with payers, with the entire healthcare system. And so the commitment was that by the end of 2016, 30% of payments would be tied to value. So some sort of quality payment program. And by the end of this year, 2018, there would be 50% aligned to that. So we're hoping that, with this administration, some of this will continue. How many of you were at HIMSS in Vegas a few weeks ago? Man, you guys aren't providers. You guys don't gamble. What fun are you? Okay, well, HIMSS was huge. It was like their record-breaking year, close to 44,000 folks. So I mention that because Secretary Azar announced the HHS priority. So you have the Obama legacy, now is with Secretary Burwell, and now it's with Secretary Azar. So their priorities are those 4 that you see that we know about, that has been tweeted in the last hour or so. It could change in the next hour. So number 1 is to accelerate this movement. So we've been all, since the departure of Secretary Price, we've all been wondering, well, what's going to happen? What's going to happen to macro? What's going to happen to value-based payment? What's going to happen to this movement? Is it going to slow down because the train's left the station? So where are we going? So we were happy to hear that there will be an acceleration of this transformation and from volume to value. We don't know how that's going to be implemented. We're hopeful it'll sit in the CMMI department and really accelerate more programs for alternative payment models. That's number 1. Number 2, combating the opioid crisis. We're happy that our president's finally on board with that. Number 3, as Dana mentioned, bringing down the high price of prescription drugs. With Secretary Azar's background, hopefully that will happen. And then addressing cost and availability of insurance, especially in the individual market, as Peter mentioned. So the stabilization of the ACA. So these are the 4 priorities for this year. And why do I mention that? Because it blends into how is CMS going to implement some of these priorities as part of the HHS, the department. So Seema Verma then came out at HIMSS to announce their kind of 3 initiatives. I think she announced the Blue Button and the My Health e-data at HIMSS. The other initiative that you see there is patients over paperwork. So decreasing the quality measure sets, streamlining them, making the measure sets more parsimonious for providers so that there isn't that administrative burden for them. So as you can see, technology is key for this administration. Interoperability will also be key. How many of you heard about Apple's now deal with, I think, 15 different health systems to really get their EHR and their data? Well, that will be the new Black, I'll say, the new Uber, the new disruptor for this year. And we'll see how that goes with artificial intelligence, with predictive modeling, and the sort. So this will be interesting to see how patients' data, as they control who they offer and share their data, how will it be protected, how will it be safeguarded, and it'll be interesting to see this year. So with that, I move into kind of what America's Physician Groups has for our members and has for just for general public consumption is our Standards of Excellence program. And it is a program that allows our members to understand the attributes that is needed to deliver risk-based coordinated care. So we provide a roadmap, 6 domains surrounded on patient-centered care, care management, HIT, those type of processes to understand how do you deliver well coordinated care. So I'll get back to SOE in a minute. So courtesy of Integrated Healthcare Association, and Jeff will talk more about this, so we're going to tag team today. We orchestrated this well. So I'll introduce these concepts for those of you who are not aware of the data that's out there. So IHA released an atlas, and this is the new and updated Atlas 2.0 version. So it tells you that in managed care, HMO outperforms PPO in all 10 clinical quality measures. I'm going to say that again. HMO outperforms PPO in all 10 quality measures. That includes diabetes, that includes colorectal cancer screening, cervical cancer screening, breast cancer screening, a lot of key clinical measures. So HMO does better. Now, SOE, they also looked at our SOE elite, so meaning those members of part of America's Physician Groups who did well in the Standards of Excellence, who scored the 5-star elite. They actually did 31% better than the general value-based P4P population. That's also a great kind of nod and confirmation that quality, cost, affordability, and delivery of care coordination is doing well in our country with respect to our members. So quality is better in HMO. Now let's look at the utilization. Utilization's better with all-cause readmissions. This is risk-adjusted compared to PPOs. Utilization's also better with commonly overused procedures. You can see that there. Quality better, utilization better. So how about cost? PPOs are actually costlier in 15 regions in California. On average, PPOs are $338 per member per year, more costly than HMOs. So HMO quality is better, HMO utilization better, and HMO costs less. There you have it. So where does this take us? This takes us to Medicare Advantage, which is a huge position that we think will be a big game changer and already is changing the industry. And this is a position that we strongly support, having risk-based coordinated care providers in our constituents. We have providers who have solely in their business line just offer Medicare Advantage, just contract with plans for Medicare Advantage. We also have groups who are completely delegated and capitated, so for Medicare Advantage. So this is the future, and we're hoping with, as Catherine mentioned, what's the solution? The solution is to contract with groups, part of America's Physician Groups, because we are in the South, we are in the rustic belt, and so if we can penetrate Mississippi, Arkansas, and those countries. Sorry, I've been on the road for like almost 3 weeks. Those states down there to understand, that Medicare Advantage does offer you better quality, lower cost, and better experience. So as you can see here, consistent with HMO data, MA outperforms fee-for-service in all the 10 clinical measures across all the 17 regions in California. MA has better utilization for all the utilization measures compared to fee-for-service. And then fee-for-service is more costly. I think this is no surprise to anyone. So on average, fee-for-service is close to $5,000 per member per year more costly than MA. And further, not only is it better care, lower cost, and higher quality MA, if you have MA, you'll live longer. This is a study, American Journal of Managed Care, showed that those patients with Medicare Advantage had a 6% higher survival rate. There was a 6% preventable readmission rate, which is very low for MA, and then 11% fewer hospital admissions and emergency room visits. So not all, you'll also get this living longer, this increased survival, decreased mortality rate. So these are the solutions that we offer for our members. This is also free for public consumption. So we have a risk readiness tool for those who are trying to get into the risk space. So let's say you're an MSSP track 1 and you want to go into a 1+, a CPC, a next gen. What do? We have a checklist that'll help guide you through that. Also, we have an APM guide from last year that kind of is a case study that illustrates where are the best practices, where are the lessons learned within our constituency. And then, of course, our annual conference is coming up. So.
Thank you.
Yeah.
So, Amy, this is optimistic, I would say. And the role of physicians is really crucial to the future of healthcare and to the future of healthcare affordability. But do we really have enough physicians to do this on their own, or do we need other members of the healthcare team, in particular nurses, to expand this, particularly in rural areas? And could you just talk a little bit about what the implications of this strategy are for manpower or woman
Sure.
power?
And pharmacists. Pharmacists.
Yes, absolutely. So, so I think I could stand here all day talking about physician shortage and burnout and all that stuff, so I won't do that. So yes, it requires the entire care team. So I think if I wasn't clear about that, that is the new dimension in terms of the care team. It is the best practice. The studies have shown that, yes, being physician-led, having a physician-led organization does lend credibility and offer a trajectory for success. However, yes, it is a care team, and a care team involving your mid-levels, involving the pharmacists. So the entire practice transformation model that we're trying to execute across the country with respect to care teams and those optimizing at the top of their license.
Yeah, that's terrific. And I have to say, though, not all physician groups are as inclusive. Because there's still efforts to resist letting nurses practice to the full extent of their licenses in some areas. So we are going to need everyone working in a team-based care, so thank you for that. Yeah. Okay, we have a few minutes, and I hope that anyone who has a question can keep it pointed and brief, and we'll try to get as many as possible in the next few minutes.
Thank you, John. Alex Capron. My question is to follow up on the exchange you were having with Dana about a value-based idea around pharmaceuticals. And I want to ask Dana, granting that there are many times when the complications of multiple conditions make it hard to measure the value because you cure one condition and the person still has all the others, which was the problem John raised for you. Your chart on the HIV drugs said $63 billion to the pharmaceutical companies, $1.4 trillion in social benefits. Is that what they should get?
Well, I think it's a good question. What is the right amount? And actually, we don't know. I mean, you know, some have looked at that and said we under-incentivize things. So, for example, I think coming back to, let me give you a concrete policy solution that maybe John will agree with and maybe he won't. I think if you look at Julie Zissimopoulos' work, if we were able to prevent the onset of Alzheimer's, it could save the health system somewhere on the order of $250 billion to $1 trillion over the next 20 years. I would argue that we should impose, instead of having a 5% holdback for quality on physicians, I think, and I remember at Rand once, they gave me a 5% bonus. It didn't change my behavior at all. If we're not going to go to 100%, then I would argue take that money, put it in a fund for Alzheimer's, and say if anyone can come up with something that will actually delay the onset, we'll give you what's in this prize. And I think, you know, those are the kinds of incentives I'd like to see. That's really rewarding value in my view.
Yeah, there are different incentives other than reimbursement. There are the idea of prizes or other kinds of rewards, but let's go on to the next question.
Hi, Mark Heinem. Covered California has been somewhat of an outlier as far as its success compared to other state exchanges. I'm sure that's due to your effective leadership and your organization here. We're very proud of that. What have been the lessons learned, and why is it that so many of the other states have had such a difficult time with this?
First, I don't think we're that much of an outlier. And we do a lot of looking at how state-based marketplaces compare to the federal marketplace. It's absolutely true that there's been a sad lesson in the challenges of having a federal approach to healthcare, which is very local. When I joined the Obama administration, we all thought there would be 40 state-based marketplaces, not 40 states in the federal marketplace. And if you look at the 14 state-based marketplaces, on average, they have a better risk mix, they do more marketing, so they are, on the whole, far more effective than the federal marketplace. So that's number one. Number two, you know, there's a combination of factors. We publish reports on what we think are the main contributors, but I think that there is a fortunate piece for California, and this is we are a pretty blue state. And I know this sounds odd in the days of single payer, et cetera, but the Affordable Care Act has not been a politicized issue in California, as it has been in many other states. In many other states, the governors have run against Obamacare consistently. And you look at Texas, you look at other states, to the misfortune of millions of people in those states. California had, and many of you know this, it was under Arnold Schwarzenegger, Republican governor, and a Democratic legislature that the legislation that established Covered California was inaugurated. And ever since then, you know, we do enrollment projects with 14,000 licensed insurance agents. And I've got to tell you, these are not the backbone of the radical left in California that are about promoting a marketplace that works. So it really is, and it's also a reminder that it's so much of the ACA really is a competitive market orientation. And that's gotten lost in much of the nation where it's been labeled Obamacare and not labeled what the tools are. So.
Mike Lowe, I have a question for Amy. I firmly believe that HMOs present higher qualities compared to PPOs. But in terms of your chart showing the 10 clinical quality measures, does that HMOs also include Kaiser as part of that equation?
Yes, it does.
Okay.
Yes, and it's not mine, it's actually IHA, so.
Okay, so it really does push it up a lot higher in terms of those differences. And the second question is in terms of survivability, pardon? Not that much of a difference, okay. And then the other one would be, in terms of survivability, we've taken into account adverse selection on the fee-for-service side.
Yeah, that's the trick.
Yes, it's risk adjusted, that study, yeah.
Okay. Last question goes to our chair, Jack Lewin.
Thank you. I'd really like to ask all of you some questions. Well, maybe we'll do that during the break. But I guess the one Dana, I wanted to ask you something about just a hypothetical. What if we took the VA system. By the way, VA has the whole formulary. Every drug's on there. It's just that you've got to go through the first line before you get access to anything beyond that, and they're pretty strict about it. But what if we took, if the VA's system became like the nation's PBM, if you will, okay, for everybody, for the whole of Part D, and for Medicaid. And you said 18 billion, but if we literally got the middleman of the PBMs pretty much out of the market, it's way more than 18 billion. There's a lot of middleman profit going into PBMs. So what if that happened? And the caveat would be that if you have an allergic reaction or you're not getting therapeutic effectiveness, you can move on to any drug that achieves that. What's stopping us from going there besides politics?
It is politics, and I also think, you know, it's very easy to part of the problem is we have segmented the market so that you think about Part D. What incentive do those plans have to get you to adhere and get on the best medication, especially if the best medication is expensive? We've gone to a system where I consider it double jeopardy now. If you respond to that first-line therapy, that's great. That means your disease is easy to manage. But if you don't, you face one jeopardy, and then you face a second jeopardy, which is the financial penalties, because you can't get access to the second-line therapy. And I think we need to solve that, and that does take some political will. But I will also say that you could pay for all of this if you got the PBMs out of it.
Yeah.
So.
Right. Okay. We've covered a lot of material this morning. All these presentations are going to be available online through our websites. I urge you to come back and look at. They're very rich. Please join me in thanking our terrific panelists.